Good morning, everybody.
Good morning.
How are
Good
you?
morning, sir.
Dr. Kamle, Anil,
Yes, sir. Good morning, sir. Good morning.
you?
Good morning, sir.
What a pleasure to see you, sir.
Arun is also there.
Yes, sir.
So you need a bit of light on you.
Right, sir.
And Pandit is there. Stalwarts. Three of them. It's almost- You started all this 50 years ago. Is it? Oh, and Arun must be very busy. So to get time from them is very remarkable. That's a big achievement. You got what? I think very soon, after perhaps 2 months, you can meet in person, I think.
Looks like, sir. Looks like. Looks like.
COVID time.
The
Uh,
unseen
Keep our
future.
fingers crossed. Yeah.
All the extraneous noise.
I think Arun Bhai's light is very poor. Arun Bhai will have to do something to illuminate his face.
I'm trying to follow Joy, you know.
Yeah, hi, sir. Good morning. Good to see you.
Very good morning. Up with me, you know, so that I like.
Morning, everybody. Good morning,
Very
sir.
good morning.
Yeah.
Good morning.
I think I can't help because my bright light is behind. That's why I'm getting dark, I think.
Yeah, you can't face the other way around.
I can't. I have to face this way only.
Yeah, that's it. But you are at home or you are at the hospital or where are you?
No, I'm at home, very much at home, sir.
Okay. Joy too?
Yes, sir. All of us. I think
So the painting on the side is
The COVID
that
has
painting is my son's painting done when he was in 5th standard. So
okay.
very much at home.
COVID has given us that much right to work Sunday from home, I think. Don't go.
Yeah, has given that right, yeah. But I think meeting in person is always better, at least for me.
Yeah, but our problem is we are getting used to it from working from home. So that should not become a habit.
Correct.
Your wife must be happy.
It may
Sorry,
become an addiction.
Sorry.
Sorry, but we are live on YouTube.
We are live.
Right. So I think you can start. So I think
So,
over the-
so we'll wait for 1 minute. We'll start by 11.
right.
Anil, you are still muted, but we can hear you. How come?
No, sir, please mute all of us. We are live.
Okay.
I should mute myself, yeah?
Yeah, we can do that.
Good morning, Kamlesh. We can start.
Yeah. Good morning.
Kamlesh, unmute. Unmute, please.
Good morning. Good morning, friends and colleagues. It's nice to see you all today morning in this webinar. The Bombay Seaboard Medical Association, apart from its various activities, is very well known for its CMEs. As you all are aware, we have successfully switched from CME on first day of every month at Sir H.N. Reliance Foundation Hospital to webinar on first Sunday of every month, which has gained huge popularity and attendance. As soon as things are better, we'll start our CMEs at Sir H.N. Reliance Foundation Hospital. Today, our CME topic is on neurology with very eminent speakers, Dr. Arun Shah, Dr. Fali Poncha, and Dr. Joy Desai. Also, we'll be giving a Lifetime Achievement Award to legendary Dr. B.S. Singhal, neurologist of international repute. My special thanks to Dr. Anil Mehta, Dr. Jawahar Mukhtiar, and the whole team for organizing our monthly CMEs. I am blessed by efforts of our sincere managing committee and members making my work very easy. We are fortunate to be joined today by Bombay Medical Union, Sir H.N. Reliance Foundation Hospital, GPA, FFAPI, the Bombay A Ward and D Ward Medical Association, as well as Jain Doctors Federation. I now hand over to Dr. Anil Mehta to further the proceedings.
Good morning. Welcome to CME on Neurology update on this very Sunday morning. Neurology is very interesting and ever young. At the same time, it is very challenging and demanding branch of clinical medicine. The academic discipline started sometime in 15th and 16th century. And we have been using many names all throughout our medical teaching at the medical school, like Circle of Willis, which was found out by Thomas Willis, Bell's palsy by Charles Bell's, Moritz Romberg's famous Romberg sign, this DMD, Duchenne's muscular dystrophy, described by Duchenne de Boulogne, and paralysis agitans, described by James Parkinson's, renamed by a very famous neurologist, Jean Martin Schacker, the famous neurologist with Charcot arthropathy, or we can say that famous Schacker's triad for multiple sclerosis, so on and so forth. So what is so unique about neurology? The diagnosis mainly revolves around a careful history taking and eliciting all the clinical signs. The modalities, the investigation modalities are mostly to confirm the diagnosis. And if you look at it, apart from the electrophysiology, most of them are very young, 1 or 2 decades, like CT, PET, MRI, etc. So that makes it so special. And our city of Bombay has been so blessed with great time neurologists. To name a few and remember them, Dr. N.H. Wadia, Dr. E.P. Bharucha, Dr. P.M. Dalal. Today, the consortium of associations led by CWARD, we have a great opportunity to felicitate Dr. B.S. Singhal. For the proceedings, I request and I hand over to Dr. Jawahar Mukhtiar.
Thank you, Dr. Anil Mehta. It's been a pleasure inviting Dr. Singhal to this occasion, and it is a privilege and an honor for all of us for him to be here today. Before we start that, I would like to introduce somebody who's a neurologist and a chip of the old block. He serves on the board of trustees at Harvard Medical. His areas of research include stroke in young adults, cerebral arthropathies, arteriopathies, advanced brain imaging for ischemic stroke, and he's the principal investigator of the NIH-funded Indo-US Collaborative Stroke Project. Let me introduce the chip today. Please make yourself visible, and please say a few words for Dr. Singhal. Hello? Can you make yourself visible, please? Hello.
Uh,
I don't know.
You had informed him?
Yeah.
Usually he is punctual.
Sir has already guessed it. No, he's there. I don't know. The iPhone is stuck, I think.
We'll wait for him,
Dr.
but we
Anish,
can continue.
are you there? Yeah. I think I would request Dr. Kamlesh Shah to please felicitate Dr. Singhal.
Good morning, sir. Fellow medics, it gives me a great pleasure to present Lifetime Achievement Award to Dr. B.S. Singhal. Dr. Singhal needs no introduction. He is a legendary and of international repute in the field of neurology. His practice spans over 50 years. He is renowned in the field of neurology. I am privileged to have known Dr. Singhal since early years of my practice. I and my patients have gained a lot from sir. Looking at his list of achievements and uh, goals, it will be very difficult for me to summarize everything in 5-10 minutes. I'll do my best, sir. Dr. B.S. Singhal is Director of Neurology at Bombay Hospital, Institute of Medical Sciences in Mumbai. After pre-medical studies at Maharaja's College in Jaipur, he studied medicine at the Grant Medical College and Sir J. J. Group of Hospitals in Mumbai. He obtained his MBBS degree in 1956 and MD in 1959. After his initial training in neurology in Mumbai, he went abroad for further training at the UCL Institute of Neurology in London, where he obtained MRCP at Edinburgh in 1960 and MRCP London in 1961. He was made the Fellow of Royal College of Edinburgh in 73 and Fellow of Royal College of London in 1985. On his return to India in 1962, Dr. P.S. Singhal joined the departments of neurology at the Grant Medical College, Sir J. J. Group of Hospitals, and of course, Bombay Hospital Institute of Medical Sciences. Currently, he is the Director of Neurology at Bombay Hospital. Sir has trained over 200 neurologists across India. He has published over 200 scientific publications in both national and international books and journals. He is known for his work in multiple sclerosis and myasthenia gravis. With international collaboration, he discovered the entity of megaloencephalic leukodystrophy in Agarwal community. It was specific gene defect. He was president of Neurological Society of India in 1986, Indian Epilepsy Association 2000 to 2002, member of WHA Group for MS and Parkinson's disease, World Federation of Neurology 2009, chairperson of the Asian section of the Movement Disorder Society 2009-10. In order to update Neurology's Advanced Neurology Foundation in 1996 and holds neurology updates meetings every alternate year. He formed Parkinson's Disease and Movement Disorder Society in 2001, which has 19 support groups in our country. He is honored nationally and internationally by having 2 Orison Awards after his name. The first single Orison is delivered every alternate year at the meeting of Indian Academy of Neurology. The second single Orison is delivered at the International Conference of World Federation of Neurology. He has received numerous awards and achievements. To name a few, in 1983, Karma Yogi Puraskar Award. Again in 1983, Fellowship of National Academy of Medical Sciences. In 1993, Rajasthan Ratna Award. In 1999, B.C. Roy National Award. In 2004, Priyadarshini Academy National Award. In 2005, Vocard Award. In 2006, Lifetime Achievement Award of Madras Neurotrust. 2009, Dhanvantari Award. 2013, Rameswar Das Birla National Award. These are the few awards amongst the many he has received. Sir, we are very honored to be associated with you, and it gives me an immense pleasure to present this Bombay Seaward Medical Association Lifetime Achievement Award to you. May I please call upon Dr. Vijay Kambati, our immediate trust president, Dr. Bharat Bhatt, president of JPA, to present the award to Dr. Singhal. And I request Dr. Singhal to say a few words.
Sir, can you show us the award, please? Yes, sir. Thank you.
Beautiful. Thank you very much, Kamlesh, for your kind introduction. A bit too long, though. A bit embarrassing, too.
I tried to shorten it, sir.
Yeah. And anyway, thank you very much, Kamlesh, Anil, Jawahar, all the people of the organizing committee for selecting me for this outstanding achievement award. So there are two aspects I should really mention. One, do I really deserve it? And if I deserve it, on what basis? And who would have contributed to whatever little I have achieved? But I have to thank several people, My mentor, Dr. Wadia, who really shaped me into neurology. My colleagues, all the resident staff, all the people who have worked with me. From the colleagues, I learned a lot. And of course, if I have any difficult issues, I really refer them to Joy or Arun, and I think they'll bear me out, and Fali, of course. So I feel that there are a lot of people who really give you a hand to prop up to say that you are achieving something. It's not a solo effort ever. And I think I have to thank all the people who have been my colleagues like Dr. Jimmy Lal Kaka, Rup Goswami, and several others. Difficult to name them all, but I think they have contributed immensely in every activity that I have done. And even the collection of the data and things, and the colleagues that were at JJ Hospital and Bombay Hospital. So I think I'm really, this achievement award that you're giving me, I am accepting it with on behalf of all the people who have really helped me to achieve this. The second important issue really is that to achieve the award from this will be the best award that I've ever achieved, because this is from the pillar of medicine, and that is the family doctor. And I think the family doctor is really the pillar of, you are the friend, philosopher, and guide, as they say. And as you know, even in America, they have a special branch of medicine which many people prefer, and that is the family medicine. You know the family, you know the ins and out. And I think anybody who bypasses the family doctor makes a big mistake. I know that many of them land up with the surgeons, and the surgeon is only in the habit of looking at the recently discovered, as Anil said, MRI picture. And he finds that there's a bit of a compression of the nerve root. He doesn't bother to take any history or anything else or examine them. And he just goes and operates. And only when the patient is still not recovering and has weakness in the legs, and then it goes to the Dr. Joy Desai or Dr. Arun Shah, and they find out what exactly the cause, which of course is the medical reason in the spinal cord. So I feel that many of the mistakes are committed, and in fact, it's been my practice actually that apart from taking the name and the history and the age and sex of the patient, I want to know who the family doctor is. And of course, I do make a mistake of accepting the patients who are coming directly, but I invariably send them back. I find out which area they are staying and who the doctor is. And if I know him, I really refer the name. Otherwise, I tell them to find out and not to contact me again without consulting him. Because, we may prescribe a drug and the person may be allergic to it, which the family doctor will know. And it's unlikely that the patient may remember. And suddenly you may find a catastrophic anaphylactic reaction as a result of the drug. And the drugs have so many names now. The carbamazepine is not only carbamazepine, it's Tegretol and so many other names. So I feel that it's very, very important that the person goes back to the family doctor. He knows the history. And he knows the person, from probably the birth to, adulthood, his marriage and everything. So I feel that is very, very important. And I find that the only thing which I think I've always felt, those people who are practicing solo, because you're available all the time, 24 hours of the day. And therefore, unless you have a group or you have people helping you, some of you have created a group which really, so that you're available all the time. So we are really grateful to this, the family doctor. And even he would know everything, even though he may not be reading, but he would be getting educated from the specialty that he goes to, and probably he knows a bit more. He would know when to order the CT scan or MRI scan and when not to order it. So I feel that this is a very, very precious award to me, because it is coming from the people who really matter in the society, the family doctor. And thank you very much indeed. I don't want to keep you away from the very, very illustrious speakers that you have chosen, Joy, Arun, and Holly. Thank you very much. Very kind of you.
Jawahar.
Thank you, sir. Thank you for those very kind words. Unfortunately, general practitioners seem to be withering away in a lot of places, and we need a few kind words like these to boost this group of doctors everywhere. We would now proceed. I was hoping that Anish would be able to join, but I somehow think there's some technical glitch, or he's not able to join in. We'll try to get him a little later if possible. I will now invite, I think, Dr. Anil Mehta to come forward and introduce the next speaker, Dr. Arun Shah.
Good morning. Dr. Arun Shah graduated with an MBBS from the prestigious St. GS Medical College in KM Hospital, was awarded several gold medals, and he completed his MD in Internal Medicine and DM Neurology in the same institution. Then he proceeded further for the fellowship in cerebrovascular diseases in Portland, Oregon, USA, where he participated in research projects involving therapy of acute stroke. This has continued his interest in the field of stroke, and he was the first one to use the reperfusion therapy in acute stroke in city of Mumbai in 2002. He was amongst the first few to present his data from India at the World Congress of Neurology meeting held in Sydney, Australia, 2006. In addition to being an active clinician, Dr. Shah has been popular teacher, having trained more than 30 neurologists and developed an outstanding department of neurology at TN Medical College and Nair Hospital, which is my alma mater too, where he retired in 2008. Dr. Shah is at present emeritus professor at the Department of Neurology in Topiola National Medical College, and right now he is the Director of Neurology and Consultant Neurologist at Sir H.N. Reliance Foundation Hospital, Mumbai, and Consultant Neurologist at Bridge Hospital Trust, Mumbai. So may I request Dr. Arun Shah to present. Sir, you will have to unmute, please.
I was his examiner, by the way, and I think he did extremely well and got the gold medal, I think.
Yeah.
By the way, I need not be able to join because it is past midnight over there.
Yeah.
And I think he might be fast asleep.
Before I begin my talk, I have to give some regards to the most popular teacher and popular neurologist, Dr. Singhal. And as Dr. Singhal just mentioned to him, this is one of the things which I always remember, that he was my examiner in 1980. And about 10 years later, we met somewhere in a sort of post meeting drinks or tea, and he remembered that. And not only he remembered that, he also remembered the long case which I had presented to him. And I think that what shows the passion for minute details which is behind his success, and I would believe that. And we all tend to include him as a role model, try to go in full steps. Of course, we have miserably failed, I must say that, despite that. And I wish all the best to sir, and I'm looking forward to the Neurology Update Mumbai 2022 and many more to come. Thank you, sir.
Thank you, Arun. Thank you. It was a case of polymyositis, by the way.
Yes. How many years now? That's great. Great.
Sir, can we start?
Right. Can I share my screen now, or how is it going?
Yeah, yeah, sir. You can share. Sarah.
Good morning, friends. This is a topic which I have never spoken to, and Dr. Jawahar Mukhtar thought that this was the topic which a family physician should know about, and that's why I have tried to assemble my thoughts and give a small talk. I might exceed few minutes because we are early. I think that should be allowed. So the topic, of course, is differential diagnosis of tremors, but of course, some management issues will also be covered as expected, because this is a practical talk more related to management of patients. So let's come down to what is the definition of tremor. First of all, is the most common involuntary movement disorder seen in clinical practice, and is defined as a rhythmic. Every word is important: rhythmic, involuntary, oscillatory movement of a body part that is brought about by alternating or sometimes synchronous contractions of reciprocally innervated antagonistic muscle. So obviously, the commonest body part involved is the upper limb, that is hands, but you can develop tremors of the chin, tremors of the head, voice tremors, and so many so forth. So, but this is what is the definition of tremor, and as expected, is one of the commonest movement disorders seen in clinical practice. The problem is when you deal with a patient with tremor, your three important questions you need to answer: is the movement disorder actually a tremor, or is it something else? And second is the tremor isolated, or are there accompanying neurological abnormalities? Is it a tremor is part of a generalized neurological disease process? And finally, what are the phenomenologic features of the tremor? That is it static tremor? Is it is postural tremor? Is it action tremor? And this is what the phenomenology has to be decided at the end. So once you have answered these three questions, the differential diagnosis becomes easier. So the first, obviously, as everybody has emphasized, the clinical history, which of course the family physicians know the best when what the physician is. And I always prefer if the family physician accompanies the patient, or at least tells me the family background of a person, that the diagnosis becomes much easier. So age and onset. So obviously most of the tremors, particularly the degenerative varieties or the familial varieties, start much later on. It is a bimodal distribution, but generally they would start after age of 40 and 60. But if it starts in a younger age group, I know that I may be missing a neurological disease, and I would probably investigate in data. As I would show you in further presentation, that age of onset does matter, as well as differential diagnosis affected. Which part of the body is affected is the next question one has to answer. The nature of onset. No, most of the tremors do not start acutely. So if you have acute onset of tremor disorder, more likely that it will be functional or non-organic tremor. So most of the tremor will start insidiously and progress, except for certain drug-induced tremors which may start acutely. How is the course of the tremor? Is it static or is it progressive day by day? That also matters. Exacerbation and relieving factors. This is very important in the history, particularly for the diagnosis of, for example, essential tremor, which is relieved by alcohol intake. So if you get a history that a person over the weekend drinks a couple of pegs and the tremor completely goes away, you know that you may be dealing with essential tremor. What are the associated neurological symptoms and signs? So for example, slowness in movement or any other gait imbalance or gait ataxia would tell you whether it is a cerebellar tremor versus Parkinson tremor. So symptoms, history of associated neurological symptoms definitely helps us further in differentiating associated systemic symptoms, such as a person has a history of thyroid disorder, or he has features suggestive of cortisol excess, such as glucagon features, or is the long-standing diabetes or alcohol history, and all this associated symptoms also will narrow down your differential diagnosis of tremor. History of exposure to drugs is very crucial in diagnosis of differential diagnosis of tremor. The family history is crucial again. And finally, in order to decide what kind of management is required, one has to understand whether the tremors is it significantly affecting his day-to-day activities, and is there a functional disability, because the treatment will depend on whether the functional disability is there or not, because sometimes mild familiar essential tremors, which is not disabling, you may not do anything except reassuring him. When you see patients after the history, you do an examination. So there are examination, you have a 7-step approach. First is examination with arms at rest, and the rest is crucial. I'll be giving some tips in the next slide. Examination with arms outstretched in front of, also front, the outstretched hand test. Then of course another outstretched hand test is the wing beating posture, which I think will come to. Then examination during movement. The most common movement obviously is finger to nose test, but you can also do many other tests which will come to. Then the patients then ask him to write or a draw or Archimedes spiral. And this is very important because not only for the diagnosis and differential diagnosis, it is also important for follow-up, because if you keep his handwriting and keep a sample of Archimedes circle which is drawn and you give them a drug treatment and to follow it up, it will help you to decide whether the treatment is working or not. And as mentioned, the examination of a neurological complete examination is equally important. Is there a cerebellar signs? Is there a cogwheel rigidity? Is there a bradykinesia? Is there a dystonia? And was there a localizing signs such as nystagmus, eye signs? All that will help you to decide whether the tremor is part of a neurological disease rather than the only tremor disorder. And the systemic signs which are history-wise, which are mentioned. So you look for signs of hyperthyroidism. You can look for eye signs for hyperthyroidism, and probably look for some signs of alcoholism, and all that will help you to narrow down. So systemic examination is equally important to narrow down the diagnosis. So tips for examining patient with tremor. So these are important practical tips. Do not rush the exam. Remember that some forms of tremor take 30 seconds or more to emerge. So when you take a patient, call the patient when you have time. Patience is a virtue. Examine all patients in the true rest position. So sometimes it is very difficult to achieve rest. We have seen in practical exams. Ask the person to sit and rest his hands is very difficult. So sometimes what the trick we could use is ask him to count backwards from 30 or 100. And when he does that, probably he'll be relaxed. So the hand should be pronated, resting on the lap with a thumb upside and the little finger down. This is the position which is recommended, which I'll show in the next video. Then, of course, you ask them to do outstretched hand test. Ask patients to raise their arms forward in outstretched position, holding it for at least 10 seconds. Then the wing beating part, request to hold arms outstretched to the sides in the wing beating position for at least 10 seconds. Then you do a finger nose test, assess patient's ability to repeatedly bring the finger to the outstretched arm. And during that press, you notice you have to look at the tremors during the finger nose test action. Also, what happens when the finger reaches the tip of the nose, that is the intention component. Ask the patient to write in both script form, that is, you can ask the patient to write an address so that there are 3-4 lines there, or draw Archimedes spiral, but it has to be turned so that he's not resting his hand on the table. It's important that Archimedes circles, one should not ask him to raise the hand, it should be free. And then, of course, study the maneuvers which trigger them, such as ask the person to drink water from a cup or pour water from one cup to the other. So this is what a complete examination of a tremor probably will give you enough information to come to a almost definitive diagnosis, and you may not need any further testing. So I'll be just showing you this video. This is very important. This lady was not approached to me for tremors, but she was hospitalized for some other cause, and this tremors I was referred to me that she's diagnosed as Parkinson. Have a look at her, and that's why we saw. So this is an 80-year-old lady with a history of tremors affecting both hands for the past 30 years, and was labeled as Parkinsonian and was given levodopa carbidopa for the last 20 years. She has been taking this drug with hardly any benefit. The family history was positive for tremors in other family members. And if you see, this is the rest tremor. So you can see a rest tremors of the right hand. The left hand, there are no tremors. And when we do an outstretched hand test, it's shown here. So she has a low frequency coarse tremor. And this is the wing beating posture, which I was talking to you about, where again, she has tremors of both the hands in this position. And in this particular posture, particularly is important to bring out the proximal tremors. The tremors can be distal or proximal. So when the tremor affects shoulder and elbow, probably you require this posture. And then you do a finger to nose test, which of course is routine. Everybody knows about it. And so what you notice here is she has a tremor throughout the action, but not so much of intention. So not at the end. So she has action tremors or a kinetic tremor. That is what we call it when the tremor occurs. And this is better seen on the right hand. She has severe kinetic tremors, but there is no intention component. The tremor doesn't worsen as the she approaches the target. And that is important sign to be remembered. You can see it again. And then she, of course, also had what is known as chin tremors seen here. Very slow amplitude tremors. And then, so this example, what I showed you, I'll come to the diagnosis. Obviously, she had no Parkinsonian features whatsoever. What she had is an essential tremor with some resting tremor, and which was well elicited by various maneuvers which I showed. Coming to the Archimedes spirals, this is very important test which helps you to differentiate differently. So in Parkinson's, this is normal. Then persons with Parkinson's disease, you will see a micrographia. So the circles will be very small with very small amplitude tremors seen here. And when in essential tremors, the person will have large amplitude tremors that you can see it all around. And this, of course, helps you for a follow-up as well. And this is the handwriting of a person with Parkinson's disease, typical micrographia, as you could see here, and it becomes smaller and smaller as towards the end of the writing. And with the essential tremor, you will see a large amplitude, large handwriting, which doesn't make any sense. So what are the types of tremor? They are resting tremor. Then that means the tremors which are present at complete rest, which when we how to achieve that posture we already talked about. Then you have postural tremor, which are the tremors which occur at outstretched hand test. Then you have action or kinetic tremor, well demonstrated by doing an action. So the commonest action we do bedside is the finger nose test. So during finger nose test, while the finger touches the nose, in between when during the entire target motion, you will see tremors. That is called action or kinetic tremor. The intention tremor is a tremor which occurs when the target reaches the nose. That is called intention tremor, and those are particularly characteristic of cerebellar tremor. But cerebellar tremor are not there so much in action, but when a person reaches target, you will see a force tremor. And then you have something like what is a task-specific tremor, right? Somebody gets tremors only while writing, so primary writing tremor. So these are the different types of clinical tremors, which phenomenology, which you should remember, and this is what one likes to do at the end of the examination. So this is what generally the tremor will consist of all this. Of course, the diagnosis of tremor and all the, there are a lot of controversies going on, and Movement Disorder Society is working on it. We'll not go into all this, we'll just go to the bedside what we do. So the commonest tremor, of course, is the physiological tremor, which as is shown here is mainly postural. Then you have essential tremor, which again is postural as shown in this lady, which the example we had, but she also had resting tremor. So some of the people with essential tremor, as the things progress, may develop additional essential tremor, and they also have action component. Parkinson's disease tremor is predominantly a rest tremor, as you see here, and they may have postural component, may have a little bit of action component. But most important characteristic of Parkinson's disease tremor obviously is that as soon as you do a volitional movement, it suppresses. So there is a suppression of tremor with volitional movement, and which may re-emerge if you keep the pressure. Then there are drug-induced tremors, which obviously, I guess, mainly are postural. Dystonic tremors, pretty rare entity. We should not worry so much about it. We will come to order. The important orthostatic tremor I want to emphasize because it is missed very often. So there is a classic history, which I'll show the case history. The metabolic practice, such as hypoglycemia, thyrotoxicosis, can cause tremors, which are mainly postural. Neuropathic tremors, chronic neuropathy can have tremors, acquired as well as genetically determined. The Holmes tremors, which is usually due to tremors in the unilateral tremors in a person with a red nuclear region, that is red nuclear tremor. Cerebellar tremors are predominantly posture and much more action. And of course, psychogenic tremor will not have very proper characters. It will vary from person to patient. So the other way to differentiate tremors is on the measure of amplitude and frequency. And we'll see that mostly Holmes tremor and cerebral tremors have much more higher amplitude with a very low frequency. The Parkinsonian tremor is again between 3 to 6 hertz and probably has little lesser amplitude. Essential tremor 5 to 8 hertz. Enhanced physiological tremors are the ones which are very low amplitude but have faster frequency, and orthostatic also have low amplitude and faster frequency. So sometimes the amplitude and the frequency helps in the differential diagnosis. So just a word about pathophysiology. It is not very fully understood as expected, but obviously it has several factors. You can have the mechanical oscillations which occur in physiological tremors, you have reflex oscillations which occur in thyrotoxicosis or metabolic disorders, or you have central oscillatory system which is active in people with Parkinson's disease or essential tremor. We'll come to that in a minute, and cerebellar dysfunction also. So this all combination of factors contribute to genesis of tremor. And so mechanical oscillations of the limb occur in a particular joint, and this is a mechanism generally mediated by sympathetic nervous system, and this is what we see in physiological tremors. When the reflex oscillations are people who have exaggerated physiological response, and that's generally seen in hyperthyroidism or toxic. And the central oscillators, as I mentioned, which consist of thalamus, basal ganglia, or inferior olives, and these are active particularly in people with Parkinson's tremors and essential tremors. And abnormal functioning of cerebellum is seen in most of the type of tremor by PET studies, which says that cerebellum does contribute tremors in most of the type of tremors. Now coming to physiological tremors, is a very low amplitude fine tremor, 6 to 12 hertz. That's barely visible to the eye. You have to put a fine paper and outstretch hand test, and you'll probably see it better. You can accentuate those tremors by that. Very common in normal people and does not interfere with activities of daily living. Enhanced physiological tremors is the typical which we see in thyrotoxicosis and anxiety states and low glucose. And obviously, treatment of these tremors is to treat the metabolic etiology in anxious patients. You use anti-anxiety drugs, and if the drug is responsible, try to get rid of the drug. Essential tremor come to that is one of the important part of this discussion is the most common type of tremor. The prevalence ranges from say about 300 to 400 per 100,000 per person over the age of 40 years, which is mainly postural as shown in the video. It may have action components, frequencies for 8 Hz. It's usually asymmetrical, but we have seen rarely asymmetrical essential tremors. Most commonly, hands are involved, 95%, but at times you can have head tremors and you can have voice tremors are not unusual. So hand tremor and voice tremor sometimes go hand in hand. Leg affection and trunk affection is very rare. I've hardly seen. It's extremely rare, except when you are dealing with SCA12, the sinus-cerebellar ataxia 12, where the tremor, it mimics essential tremor, except that in addition is ataxia and leg tremors. So whenever you see leg tremors in people who's diagnosed as essential tremor, one should do a genetic study to rule out SCA12. The amplitude may increase and the frequency may decrease as the time goes with the person ages. So usually it is autosomal dominance with incomplete penetrance, worsens during eating, drinking, and writing. This is important. So in certain tasks, they have a lot of disability. So sometimes essential tremors, they can be very disabling, and probably the cup of tea or eating becomes so difficult that you have to use your both hands or somebody has to feed them. So advanced essential tremors can be very disabling. And as I mentioned, I had shown in my example, then long-standing essential tremors sometimes have mild resting tremor, as shown here. And when the head is involved, you have generally yes tremors, but at times you can see no tremors also in essential tremors. So most important diagnostic criteria is improves with the relaxation of alcohol. In 50% reduction occurs when a person takes, and that maybe some of the people with essential tremor develop a habit of taking a drink before going to a party. It may be associated with gait difficulty or tandem gait and decreased hearing. And then certain variants of essential tremors are task-specific features. There is primary writing tremor, or sometimes you can have isolated voice tremor or isolated chin tremor. How do we treat? So mild disease, when it is not disabling, you may not treat at all because the mild treatment will have more side effect than the disease itself. So decision to treat based on age, coexisting morbidity, prior drug exposures, contraindications. And so as usual, one has to consider the individual factors and then decide whether treatment should be given or not. And different body parts may respond differently to tremors. For example, in essential tremors, people with voice tremors and hand tremors, the hand tremors may respond to your medicine, but voice tremors may not respond to your medical treatment. So the commonest drug, which obviously is propranolol. If there are no contraindications, that's a drug which we start for because it is benign, and probably can wait with that for some period of time. And if there is anxiety factor, probably the combination of propranolol with clonazepam at night works out very well in the initial stages. Sometimes if a person has other comorbidities, such as overweight. I have used topiramate with good success. Gabapentin also can be used. But the most important drug obviously is a primidone. The primidone is a drug which is difficult to use, and unfortunately up till now we used to get only 250 milligram of primidone. And when you have to start with only say 25 milligram or 50 milligrams. So what I used to do earlier is make the tablet, crush it and make it 1/10 part and start with 1/10 and gradually increase it. If you start somebody with half tablet or full tablet, he'll never come back to you. So it's a drug which is difficult to use, must start very slowly and gradually increase the dose. The nowadays, of course, certain companies have come out with 25 milligram tablets, and that has been a boon, which was not available till 2 years ago in our country. The important point to be remembered is primidone side effects. It does produce sedation, nausea, dizziness, and confusion. And recently, I came across a person whom I was treating with essential tremor, primidone, going on to almost 100 milligram 3 times or so. And he came to me with this severe pain in the left hand, with inability to work, and also pain in the shoulder. And then people said that his hand has become now weak, and that's how he was referred back to me. When I examined him, he had, of course, swelling of the hand with marked restricted movements of interference joints, and her shoulder movements were also restricted. And what I made a diagnosis of shoulder hand syndrome, and that is one common side effect of primidone, which was also seen with phenobarbital. So reflex sympathetic dystrophy or shoulder hand syndrome is a common important side effect of primidone. You will see rarely, but don't forget it, because unnecessary investigations end up doing everything. And this man, his primidone was withdrawn, and in about 6 weeks time, I introduced gabapentin, and his pain completely disappeared and he recovered well. So when you use drugs, the important thing is remember that side effects, and they are very important to when you follow it up. And for family physicians, this is very particularly important point. So when many of the essential tremors would not respond to the drug therapies, and that's why the botulinum toxin therapy is one of the things which is recommended, particularly in people with voice tremors or task-specific tremors such as writing tremors. So in writing tremors, there's a good success rate of botulinum therapy. Of course, this has to be done properly under the EMG guidance if possible, to select out the muscles which are overacting and then inject them, and it gives you relief for at least 6 months or so. So that is one thing which has a long-lasting effect, and it should be used. Anxiolytis, which we already talked of, and in certain situations when essential tremors are very disabling, one could consider surgical treatment, which is of course the deep brain stimulation or DBS involving thalamus. So the DBS is used as an interventional treatment for essential tremor, but it's also used for dystonic tremors as well as in refractory Parkinsonian tremors, and rarely it has been used, recommended in cerebellar tremors, not with much success, but of course it is a good treatment for essential tremor, Parkinsonian tremor, and dystonic tremor. And of course, there's a new thing which is going on, which is there for last 3 years now, is MRI guided focused ultrasound treatment for tremor. The centers in US which are doing this and thriving on this as a big business is where this is a non-invasive way of putting a lesion in the thalamus. Ventro intermediate thalamic nucleus is lesion is put. The novel technology focuses multiple beams of ultrasound energy precisely and accurately on the targets deep in the brain, and this is what ultimately happens. You burn up area of the brain, and there's a good result. It's a non-invasive. Only thing is you have to remove your hair. So you have to just hair when you go for this treatment. That's the only issue. And I think still it's not available in India, but soon we are thinking of setting up this MR guided focused ultrasound treatment for tremor at Reliance Foundation Hospital in near future. So go to Parkinsonian tremors. I already mentioned what are the characteristics, and I would not go into further repeat, but you must look for associated signs such as hands, legs, and very characteristic feature of a pill rolling tremor, which is present at rest and only with activity it is suppressed, and the associated micrographia, bradykinesia, rigidity. So all this is obvious. As opposed to essential tremors, Parkinsonian tremors most often start on one side and then go to the other side. And this is the table which basically mentions the same differential features of the state. So let's move forward. But important point to be remembered is people with Parkinson tremor, essential tremor, are sometimes prone to develop PD. So you have a combination of tremors, and that sometimes difficult to diagnose, and that's why we use that scan to differentiate whether there is associated Parkinson disease or not. We will come to that scan, and that is one investigation which is recommended in people with essential tremors and PD when you have difficulty in differentiating. So the treatment of Parkinson tremor is probably same. Anticholinergics, the DA agonist and levodopa supplement works in a different way. At times, the tremor is never completely controlled, and I always tell my patients that do not worry about mild tremor because these are not disabling and they go away as soon as you work. Except in some people, tremor-dominant Parkinson's tremor becomes very disabling, and then thalamic DBS is used if they are not responsive to drug therapy, and with good success. So functional neurosurgery is recommended in them. Cerebellar tremor, very low frequency tremors occurs mainly in intention component, and they may have postural component, and you'll always find associated cerebellar signs such as ataxia, dysmetria, dysradiakinesia, and dysarthria. And of course, this can be best elicited by finger to nose test and intuition. Then you have cerebellar titubation of the head or bobbing or head tremors, and this can be seen in hereditary ataxias, multiple sclerosis, with long-standing multiple plaques in the brain, and traumatic brain injury, post-stroke syndromes also you know. And no medication has been consistently successful, and with various medications is tried, it's not success, and thalamic stimulation also been tried, it's not success. A point about psychogenic tremors, onset generally acute onset, if you see, and irregular frequency, and if you see variability, the axis, tremors sometimes are straight like this, and then you change this axis. If you ask it to change, probably it will change the axis. So if you see variability, and if you demonstrate that of acute onset tremors, probably think of psychogenic tremors, abrupt onset, waxing and waning, periods of remission, history of movement tremor, body region with body region, equal presence, variability of tremor frequency, variability of tremor axis. So if you can demonstrate all these features, you should make a positive diagnosis of psychogenic tremors and should not have a negative diagnosis because you can't explain. You should not have. This is the Holmes tremors, is a rubral tremor. The characteristic I had also mentioned, it is usually a region here and this small short video which shows you the characteristic of the rubral tremor. It is the right hand. There's a wing beating tremor of the right hand, which are at posture and action. And the lady had a lesion between the midbrain and the red nucleus, which caused this. The dystonic tremor are the occurs in the body region affected by dystonia, and you can have postural action, and you can have no tremors. The commonest dystonic tremor which we see is in the neck, and generally occurs in people who are likely to develop plasmodic urticaria and dystonic tremor. And this probably responds to tetrabenazine and clonazepam therapy, and sometimes you could use Botox therapy as well. And the other new thing which is coming up is many of these tremor dominant Parkinson's patients, which used to label, they don't have any other features except tremor is a major feature. And they now are turning down to be having dystonic tremor rather than Parkinson's disease. So there's a new thing which is coming up, and probably we know more about as the time goes. Important to remember there are CIDPs or chronic inflammatory demyelinating neuropathies, and certain hereditary Charcot-Marie-Tooth disease may present with tumors, particularly CIDP, which is associated with paraproteinemia, may have tremor. These are 3 to 6 hertz hand tremors, and generally they will always have signs of peripheral neuropathy, so you probably make a diagnosis easily in these people. This is, of course, difficult to treat again. Various things are tried, clonazepam, primidone, but not much success in them. The palatal tremor is, there are two things. One is symptomatic palatal tremor because you have a brain lesion, a demyelinating or a stroke, which gives in the Mollard strangler, gives you this tremor, palatal tremors or tremors of the palate, or you have an entity of essential palatal tremors, usually not associated with CNS lesion, and their main complaint is they have clicking noise in the ear all the time. And this is just an example of palatal tremor. You could see rhythmic jerking of the palate. You could see here, and generally, treatment is difficult. Clonazepam has been tried. Clonazepam valproate has been tried, and sometimes you could use a botulinum toxin in the palatal muscles, and that probably gives you good relief. The drug-induced tremors is a very important point, which is remember there are various drugs which you give, which can give you physiological tremors, rest tremors, reaction tremor. And the list is very quite here. The alcohol, amiodarone, the corydoron used for many years can give you rest tremors, amphetamines, beta blocker, beta adrenergic agonists used in asthmatic patients, caffeine, cyclosporine, dopaminergic drugs, long-standing corticosteroid therapy, theophylline, thyroid hormones, valproic acid. These are all can give you postural tremors. Alcohol and lithium is known to give you intentional tremor. And of course, don't forget the levosulpiride is the one of the important drug which is used in this combination of breviprazole or various L compounds which used for gastric symptoms, and they turn out to come to us with resting tremors, and of course may have full Parkinsonian syndrome. So that I have highlighted that because this is very often missed, because it's L and you just prescribe and you forget that you are prescribing a drug which can give you rest tremors. And then this is an interesting history I wanted to point out. A man who could not stand still but could walk normally. Now, this is recently we saw a patient, 82-year-old hypertensive gentleman, presented to us with complaints of unsteadiness in standing position for the past 5 years. He had feeling of impending fall while standing that disappeared when he would start to walk or sit to lie down. So, and when he made him stand, within 1 minute of standing, we found him querying, and the lower limbs which disappeared when we asked him to sit down. On palpation of the quadriceps muscles, the fine rippling movements could be appreciated in standing posture, and he indicated a mild postural tremor. So we send him for surface EMG, and you would see here that here in both the quadriceps vastus lateralis, we put electrodes, surface electrodes, and you could see 14 hertz firing on both the sides when he was standing, and this would disappear as soon as you might sit him down. So this gentleman was given to we prescribing a newer drug because we thought that older drugs, which in our past experience did not work. So he was given perampanel. There's a newer anti-epileptic drug, 2 milligram once a day, and he came back to us within about 3 weeks with almost 60 to 70% improvement in symptoms, and he could stand during our examination for at least 5 minutes without any disturbance. So it's important that by history you can make a diagnosis of this and should not be. These are called orthostatic tremor, common in people with middle-aged and elderly people, characterized by unsteadiness on standing. They can walk very well, but they can't stand, and they may not stand even for a minute, and they have to hold something, otherwise they'll fall. And confirmation is done by EMG, surface EMG, which I mentioned. The recommendations was low dose clonazepam, but I just mentioned to you that perampanel, a new drug, works wonders compared to the older drugs. And if you remember this history, probably would not miss it, and because this gentleman suffered for 5 years before coming to us and getting a proper label. And of course, in a younger person, don't miss Wilson's disease. Look at their eyes. They may have, of course, associated features, ataxia, Parkinsonian features, dystonia. They may have liver dysfunction and they may have psychiatric symptoms. And you'll look at the eye and you'll see a brown golden ring around the cornea, the KF ring. And they have the characteristic tremors, but you must have, in addition to tremors, which is seen here, you will see there are other associated features. There's this bradykinesia, and also in finger nose tail you probably see tremors. Probably I'm trying to demonstrate the difference between right hand and left hand. You would notice that. See, right hand is much better, and when he does these alternating movements, you'll find that he has a bradykinesia on the left side compared to right side. And this is distinctly seen. So this gentleman has tremors, a young man with associated bradykinesia and action in intention tremor. The diagnosis of Wilson was confirmed and he was treated. The MRI brain, of course, can be abnormal in this situation and treated by low copper diet and various drugs, penicillamine, trientine, and all that. And of course, rarely, if the tremors are refractory, one has considered doing peramotomy. So what workup you will do in a patient with tremors? So obviously, depending on it has to be individualized. If the tremor, you take a good clinical history, and then you must order thyroid function test. Rarely you can order liver function test, serum cerebroplasmin level, toxic screen, drug levels, and in rare situation you may order MRI brain if you take home tremor, or if you are worried about the cerebellar dysfunction, then you order MRI brain, and of course sometimes you do FDG Trodat scan if you want to differentiate Parkinsonian tremor for this. And so it's showing here in that scan, a normal person, normal uptake of dopamine and Parkinson's disease is reduced. So this helps to diagnose Parkinson's disease, and sometimes if we have differential diagnosis of the problem, one could do that. So in summary, make sure that it is a tremor. Make sure, is it a predominant tremor or are there other neurological systemic features, so that you will be able to label them properly. And of course, you should be aware of functional disorder, or particularly tremor in acute onset. Thank you very much.
Thank you. Thank you, Dr. Arun Shah.
Yeah. I hope I didn't exceed my time.
I think you are in perfect time. Perfect time. Thank you so much. I think this was one of the best CMEs we have ever had in neurology for tremors. I think nobody's covered this topic so well as you've done today. Thank you so much again. I would now invite Dr. Saurabh Shah to come forward and introduce the next speaker, Dr. Falli Pocha.
I have to get rid of my stop share.
Yeah.
Very good afternoon to all of you. Well, it's an absolute pleasure to introduce Dr. Falli Pocha. He has done his MBBS from Nair and his post-graduation from KEM. Following that, it's DNB Neurology under Professor Naushid Wadia at Jaslok. Fellowship in Cerebrovascular Diseases under Dr. Professor Vladimir Hechinski, London, Ontario. Observership in Electroencephalography, London and Canada. Consultant neurologist at Jaslok since 2002. He has various national international papers and posters. Fields of interest being stroke and demyelinating diseases. Just can't wait to learn something really nice and interesting from Dr. Pocha. Over to you, sir.
Thank you so much. Let me start by share my screen. Am I audible? Am I audible?
Yes, you are.
Okay, great. Now I need to have a full screen.
So go to slideshow.
Yeah, I got that. Yeah.
And from beginning, the first one.
Yeah. Okay, great. So I'd like to thank the CWARD Medical Association for asking me to be part of this symposium honoring Dr. B.S. Singhal, who has done so much for neurology and neurology education in this country. Truly respect Dr. Singhal. So thank you. So let's start with this interesting topic. Can we, to make it a little more interesting, how do we approach it? That we're boring to go through A, B, C, D, E. So I was going to divide into emergencies, semi-emergencies, and chronic vitamin deficiencies. So, I mean, vitamin deficiencies, you'll be surprised, can actually be acute emergencies. And we start with the first one, which is simple B1. So the first B vitamin is an absolute emergency. And that is thiamine, and it causes the Wernicke-Korsakoff syndrome. It's commonly seen in alcoholics, but also seen in malnutrition and bulimia. And post-dialysis, we see it quite commonly, deficiency in vitamin in thiamine. Of course, there are now more modern causes such as bariatric surgery, which we'll deal with later. So Wernicke encephalopathy was initially described in 1881 by Karl Wernicke, a 33-year-old German neurophysician, who described it in 3 people, 2 men who were alcoholics and 1 woman who had ingested sulfuric acid, leading to pyloric stenosis. All of these patients had oculomotor abnormalities, and Wernicke had performed an autopsy on each of the patients, so he provided clinical pathological correlations. 6 years later, Sergei Korsakoff, a Russian neuropsychiatrist, he documented a unique amnestic syndrome, which he called psychosis polyneuritica, which now bears his name, Korsakoff syndrome. Late in the 1800s, it was postulated a common etiology for both Wernicke's and Korsakoff syndrome, but it was not until 1940 that the underlying cause was found to be thiamine deficiency. And Campbell and Russell were among the earliest to suggest the association of thiamine deficiency in their case series of 21 patients. Surprisingly, only 5 of these patients were alcoholics. The others had pyloric stenosis, gastric carcinoma, bowel resection, and severe vomiting. So it was really only in the last century, 1940, that we found thiamine as the cause. Now we have the triad of Wernicke's encephalopathy, and to remember this easily, I've developed a mnemonic. So all the vowels, A, E, I, O, U. So A for ataxia, E for encephalopathy, I for eye, O for ophthal, and U for urgent. It's really urgent. The encephalopathy can present with memory impairment, decreased level of consciousness, disorientation. Usually patients have a wide-based ataxic gait, they are unable to stand. The ophthalmic abnormalities are commonly a gaze-divorced nystagmus, bilateral impaired abduction, conjugate gaze palsy, and internuclear ophthalmoplegia. When you look at the fundus, they can have optic disc edema or even retinal hemorrhages. So there are these 3 core features of Wernicke's encephalopathy. The Korsakoff Korsakoff syndrome is both an anterograde and a retrograde amnesia. The anterograde means defect in acquiring new memories, and maybe as severe as not recalling events that occurred even in the previous 30 minutes. And the retrograde amnesia affects the ability to recall events in the recent past, but long-term memory is retained fairly well. And it is thought that the effects on memory are due to irreversible damage of the diencephalic hippocampal circuits. It's a bit artificial to separate Wernicke's and Korsakoff, so we should call it a Wernicke-Korsakoff syndrome. It is comprising a spectrum of clinical findings. What's the metabolic role of thiamine? Now, I have to actually go through some of my old biochemistry, which I haven't studied for the last 35 years. Thiamine is a cofactor for several important enzymes in the metabolic pathways that support cellular function. It's required for many enzymes such as alpha-ketoglutarate, transketolase, pyruvate dehydrogenase, and these are important to the cyclic or the Krebs cycle and the pentose phosphate pathway. If you look at this thiamine in glucose metabolism, you can see the top part where the pentose phosphate pathway, which produces NADPH, that is blocked in a thiamine deficiency, and pyruvate to acetyl CoA is blocked with the thiamine deficiency, and the citric acid cycle stops. So you don't have production of ATP, whereas you have production of lactic acid, you have production of glutamate, which are excitotoxic, and so all these various things result in cell death and impaired myelin synthesis. So that's the basic thiamine and glucose metabolism. Now, how long does it take to develop Wernicke's encephalopathy? Now, for human beings are incapable of de novo thiamine synthesis, and so we require daily dietary supplementation. The human body can store about 30 to 50 milligrams of thiamine, mainly in the skeletal, cardiac muscles, liver, kidneys, and brain. The dietary thiamine requirement is 0.5 milligram for every 1,000 kilocalories that you consume every day. So it's approximately 1.4 to 1.5 milligram per day in a patient with a typical diet. Thiamine deficiency leads to brain lesions within 2 to 3 weeks because the body's stores of thiamine are sufficient only for about 18 to 20 days. What's very important here, especially in India and among vegetarians, is that this will be even faster than in the West, which is a non-veg population would have a better diet of thiamine. Here are the regions of Wernicke's encephalopathy commonly seen in the pons, midbrain, and the thalamus. So the treatment is simple. It's intravenous thiamine, at least 1 gram immediately and for the next 3 days. But it's also very important to replace magnesium and to treat ongoing lactic acidosis. The important point here is thiamine should always be given prior to giving glucose, because we give glucose before thiamine, that increases the demand of thiamine and actually will precipitate the Wernicke's encephalopathy. So always give the thiamine before you give glucose. A similar thing happens when you refeed a malnourished patient. So this is within about 4 to 7 days of refeeding. Malnourished patients can go into Wernicke's encephalopathy because the demand for thiamine is increased. So with increased metabolic demand, thiamine and magnesium levels fall, leading to Wernicke's. And magnesium should always be replaced along with thiamine because it's a cofactor for many of the thiamine-dependent enzymes. So these are the few practical points. Always give thiamine first before you give glucose. Always give magnesium along with thiamine. Now, the deficiency of thiamine can also be subacute, where you can cause beriberi. Beriberi can be both dry beriberi and wet beriberi. We're going to talk only about dry beriberi because that affects the nerves. It causes a painful distal sensory motor axonal polyneuropathy, affecting the lower limbs more than the upper limbs. They experience limb weakness, such as foot drop, decreased proprioception, reduced or absent peripheral reflexes. In infants, commonly it's a failure to thrive between 2 and 12 months if the mother is thiamine deficient and she's only breastfeeding, or if baby formula is thiamine deficient. As recently as 2003 in Israel, there was an outbreak of infantile beriberi because they were giving an imported soy-based formula that was deficient in thiamine. So that caused infantile beriberi in a cluster of newborns. There are a limited number of studies identifying genes. We do know that the Asian population is more prone to wet beriberi, which affects the heart, whereas the European descent are more prone to Wernicke's encephalopathy or dry beriberi. We have found 4 genetic defects that predispose patients to beriberi and Wernicke's encephalopathy, and patients harboring these genetic defects are particularly susceptible to Wernicke's and require aggressive replacement of thiamine. The risk factors are with common in alcohol, but the others are poor nutrition, diminished gastrointestinal absorption, or loss from Crohn's disease and other things, increased metabolic demand, impaired metabolism. Alcohol works in many ways and would be the commonest factor in 95% of patients. As I said, more recently, bariatric surgery is found to be a cause, and it normally takes about 2 to 8 months post-operatively in patients who are losing about 7 kgs per week. It takes about 2 to 8 months to develop this. So one should always replace thiamine in patients who are undergoing bariatric surgery. Riboflavin is, again, comes to chronic or subacute, and in fact, one of the new medicines that helps with migraine contains riboflavin. Night blindness, peripheral neuropathy, are other neurological causes. Niacin is the 3Ds, remember 3Ds, dermatitis, diarrhea, dementia, and the eventual 4th is death. So we are going to deal with dementia, which can range from hallucinations to seizures, and is related to decreased serotonin neurotransmitter synthesis. Pyridoxine can cause a subacute peripheral neuropathy. Now, this can cause a neuropathy both in excess of pyridoxine or in deficiency. And they are primarily sensory neuropathies, but when you have an excess of thiamine, of pyridoxine, it affects the large fibers, the large diameter fibers. So it causes profound sensory ataxia, the excess of pyridoxine. Pyridoxine deficiencies, we have to always remember to replace pyridoxine in patients who are on INH, hydralazine, and penicillin. An excess of B6, as I mentioned, can be subacute and gives rise to sensory ataxia with loss of vibration and proprioception and a positive Romberg's test. Atrial deficiency, I would again classify as possibly an acute or subacute problem. In 1991, Houston had summarized an experience with a large group of over 1,000 patients with atrial deficiency. He found isolated neuropathy in 25% of patients, myelopathy in 12% of patients, and a combination of myelopathy and neuropathy in 41% of patients. Neuropsychiatric manifestations are memory loss, short attention span, psychosis, hallucinations, something called megaloblastic madness. Personality changes and violent behavior can also be seen in B12 deficiency. Particular findings are commonly centrocecal scotoma and optic atrophy, nystagmus, and chiasmatic lesions are also seen causing bitemporal hemianopia. So we know subacute combined degeneration causes tingling and numbness starting in the feet and going up to involve the trunk and the arms, causes vision impairment, changes in mental state, bilateral spastic paraparesis, and we have a very strongly positive Lomborg's test and a positive Babinski sign. It is easily replaceable but has to be replaced early. If you wait too long, you will develop a myelopathy which may not be so easily reversible. And this is the myelopathy. You can see the white lesion in the cervical spine, both on the sagittal images and on the axial images. Just a short, interesting point for people who are interested in neurology. Subacute combined degeneration is a combination of posterior column signs, perimeter signs, and loss of ankle reflexes. But if you have the signs of subacute combined degeneration within the Argyll-Robertson people, this would be TB dorsalis. Now, we rarely see this, but I think we are seeing it more commonly now in the HIV era. So remember, Argyll-Robertson pupil is a accommodatory reflex being present and the light reflex being absent. If you have a subacute combined degeneration picture along with a young patient who has test cavus and scoliosis, do think of reflex ataxia as your differential diagnosis. B12 and folate go together a lot of times. The metabolism of folic acid and B12 are intimately linked. So deficiency of either of them can cause megaloblastic anemia, and the neurological manifestation can also overlap. But there is a little dissociation between the neuropsychiatric manifestations and the hematologic complications of folate and B12 deficiency. I think the neuropsychiatric come a little later. The important thing to remember in folate deficiency is that all pregnant women, all women are potentially aged at potentially getting pregnant should be on folate replacement well before they get pregnant. Abroad, they fortify the bread with folic acid, whereas we don't, I think, fortify our bread here in India. So all ladies above a certain age should be on folic acid. The reason is that impaired maternal folate intake increases the risk of neurotube defects, and it does reduce it significantly, but does not totally eliminate the risk of neurotube defects. B12 and folate have fundamental roles in the CNS function at all ages. They are very needed in synthesis of purine, thymidine, nucleotides, and DNA synthesis, and so they're important to tissue growth, differentiation, and repair. Very important during pregnancy. Vitamin C is hardly important in neurology. In fact, it's almost never mentioned. But some time ago, 26-year-old healthy man induced scurvy experimentally by restricting vitamin C for about 3 months. After 71 days, he complained of numbness and sensitivity to pinprick in both legs and calves. He had developed a sensory loss over the femoral nerve on the left side by the 82nd day. And when Mayo Clinic reviewed their data for over about 25 or 30 years, they described 11 similar cases, but their main findings were that of myalgia and fatigue. So scurvy can also cause bleeding into nerve sheets. So it can cause focal nerve defect palsies. Vitamin D, we all know, causes proximal weakness, so wobbling gait and pain due to muscular efforts. It was first described as far back as 1726 by a French surgeon called Louis Petit. Your CPK and UNG will be normal in vitamin D deficiencies. Vitamin E deficiency is hardly seen in this country. It's very commonly seen in Tunisia and North Africa because it's the second commonest cause of inherited cerebellar ataxias, spinocerebellar ataxias, causing lots of proprioception, areflexia. And the reason thought is that just like G6PD protects people against malaria, vitamin E deficiency is also protective against malaria. So it's a higher prevalence of a vitamin E deficiency ataxia in plasmodium infected areas. It is caused by a mutation in the tocopherol transferase protein gene. This protein binds to VLDL, and when mutated, this deficiency prevents vitamin E from linking to VLDL and prevents it from passing into the general circulation. So the commonest differential diagnosis of inherited spinocerebellar ataxias in Northern Africa, Tunisia, would be vitamin E deficiency. It generally presents in the early ages of 5 to 20 years with different variable phenotypes and severity. It's progressive spinocerebellar ataxia, as I said, areflexia, loss of proprioception. It mimics Friedreich's ataxia. And in the later years, in the 20s to 30s, it just normally presents with purely cerebellar impairment. So it presents with dysmetria, dysdiakinesia, and dysarthria. The ectomyography usually reveals a pure sensory neuronopathy, that's a ganglionopathy. And I just last want to touch upon vitamin A, which is to see, I mean, all the pediatricians here would know that, and it's quite significant because if you see that it's the world's leading cause of preventable childhood blindness. It affects about 1/3 of children under the age of 5 around the world, causing loss of life of about 6.5 lakhs children under the age of 5, and around 2.5 lakh children in developing countries such as India become blind each year due to vitamin A deficiency. So one would not think that vitamins have such a big role in neurology, but they do, both acutely and subacutely and chronically. Thank you very much.
Thank you, Fali. Thank you. That was an excellent presentation. Really opening our eyes to vitamin deficiencies. And we'll probably have, even in years to come, see toxicity of vitamins as we are now starting to see.
Yes.
I would now invite Dr. Bharat Bhatt and Dr. Mahmood to come forward and to introduce the next speaker, Dr. Joy Desai. Dr. Mahmood Merchant and Dr. Bharat Bhatt, please.
There, but I will take over.
Yeah.
Bharat, Dr. Bharat is there. Dr. Muktiar, can I take over?
Yes,
Yeah.
please.
Yeah. Good morning and good afternoon. Let me introduce Dr. Joy Desai, who is our next speaker, who is going to talk on delirium as well as dementia. Now, it's a burning topic in our general practice, and I think Dr. Bharat Bhatt has come. Sir, can I continue, or you want to talk something? Dr. Bharat?
He's asking you to continue.
Continue? Okay. Now, Dr. Joy Desai, to hear Dr. Joy Desai, he will give a lot of joy to all of us, as his name suggests. And he's an excellent speaker, and he is the neurologist attached to Jeslock Hospital and Research Center. He's the head of the Department of Neurology in Jeslock Hospital. He's a DNB teacher. He's also attached to Sir H.N. Reliance Hospital. He has done right from his MBBS to MD to DNB, all the gold medalists. And he is an excellent teacher as well as the academic wise. His interest is so good in neurology. He loves to teach neurology. His main interest is in epilepsy. He runs in a special clinic epilepsy in Jeslock Hospital. And Dr. Joy Desai, he's there.
Yes.
Yeah. Now his interest also, his hobbies are so many, right from the hiking to photography to voracious reading and sketching. Let me invite Dr. Joy Desai with his talk on delirium and dementia.
Thank you so much. I am humbled by that very, very generous and kind introduction that you have put forward. Thank you all for asking me to be amongst you on this very auspicious day when you are felicitating Professor Singhal, whom all of us hold in great respect, awe, and admiration. And it's a great privilege to participate today. I would just like to mention a small change. I was asked to do, when Jawahar spoke to me, he asked me to do delirium and dementia. And I just thought, for the sake of unification of thinking, ideas, and conceptualization, it might make more sense for me to discuss in 30 minutes today memory and dementia. And maybe we could do delirium as an ancillary, because delirium itself is a topic that may take up a lot of time, and I do not wish to exceed the allocated 30 minutes. And so if you will permit me, we shall talk today about memory and dementia, and it's roughly a 30-minute guide on how one could understand these two intensely interlinked concepts in clinical practice when we deal with our patients. And let me share with you what little I know with some gleanings from modern neuroscience literature that has changed the way we think about this subject. Am I clearly audible? Is my audibility okay?
Yes, very much.
Good, thank you. So dementia. So the question is what is really dementia? So the best way of understanding it, it's an acquired, progressive, and an often global impairment in memory, intellect, and personality without a disturbance in consciousness. When there is a disturbance in consciousness which is predominant, it may transgress from the concept of dementia into delirium. A clinical syndrome, this is a clinical thing. We know that when we say dementia, we mean someone who's affected by processes that have impaired their cognitive abilities. It can be caused by a very wide range of disorders that can affect the brain, either in its structure itself, that means there is an alteration in cerebral structure, or in its functioning because of a temporary malfunction in the functioning. As Dr. Pocha pointed out, it can happen with thiamine, and it can happen with vitamin B12, and it can look as if the patient is actually cognitively impaired, but it's reversible. So the definition of dementia for neurologists is that it ought to be a progressive disorder which is characterized by dysfunction of the brain in at least 3 of 6 domains of brain function. So what are these 6 domains? Memory, language, personality, praxis. By praxis, we mean the ability to perform a complex learned sequential task without having to think about it. Visuospatial skills, our orientation in geographic space, and our ability to integrate what we see in a sense of space and navigate that, that's visuospatial skills. And cognition. Now, by cognition, we mean a concept which is a little abstract, but what it means, the ability to understand abstract concepts, the ability to execute judgment, which means the ability to understand the relationship between an action and a result, and to gauge that and to anticipate that. That's what we mean by judgment. And all of this can be put together in a conceptualization of what is called executive function. And very loosely, if one understands executive function, it means the function of our forebrain, the functions of our frontal lobes. And for a definition of dementia to be proposed for a suffering individual, it should affect that person's quality of life, should make that person dysfunctional from what he or she used to be. So what do we do at the bedside? When we see a patient who presents with symptoms, a neurologist or a doctor has to first ask the question that from the history that I'm deriving of this individual, where in the brain is the lesion? Is there a single lesion in the brain, or is it multiple lesions in the brain? Does it involve the cerebral cortex alone? If it does, which part of the cerebral cortex? The frontal lobes, the parietal lobes, the temporal lobes, the occipital lobes? Is there an involvement of the basal ganglia? Is there a story to suggest that by virtue of slowing of movements or tremor? Is there an involvement of the cerebellum in case the patient has dysarthria, maybe a little bit of double vision due to nystagmus and ataxia due to impaired walking? Is there an involvement of the spinal cord? So essentially, one needs to localize the lesion. The next question we ought to be thinking in our minds, what is the tempo of progression? Is it subacute? Is it chronic? Is it rapidly progressive, or is it fluctuating? Based on the tempo of progression, one could assign different pathophysiological processes. There are some processes that can affect the nervous system, which could be subacute. There are others which are chronic, and yet others that are rapidly progressive and fluctuating. And of course, then the question that arises after the clinical analysis on the basis of investigations, what is the pathological basis of these lesions? Is this change that has occurred in this unfortunate individual because of a acquired structural abnormality? Are there ischemic infarcts? Is there demyelination? Is there a hypovitaminosis? Is there invasion by a tumor, or etc.? We also need to ask the question, what is the present disability or quality of life? And very importantly, many of these patients present with a neurological dysfunction, but the underlying problem can be a systemic disorder. And Dr. Fali alluded to that. Say, example, vitamin B12 deficiency, or a depletion of thiamine from someone who's had a gastric cancer and who's been vomiting, for example, or someone who has a systemic tumor and has been given chemotherapy at times. Just the high cell turnover itself can take away thiamine and can present what clearly looks like a dementia. You can also have individuals who are on dialysis, for example, wherein thiamine gets washed out. And if this occurs on a chronic basis, the Wernicke's encephalopathy can mimic what looks like a chronic dementia. So theoretically, when one analyzes the differential diagnosis of dementia as it's taught to neurology students, one can have this kind of spread, which is taken from on the distribution of degenerative and chronic progressive dementing illnesses of the human brain. So the commonest, as you can see in green, is Alzheimer. Then there's multi-infarct or multi-infarct with Binswanger syndrome, which is a subcortical ischemia. Then there is 20% of Parkinsonism-associated dementia, either Parkinson's dementia complex or the Lewy body variant of Alzheimer's disease or the diffuse Lewy body disease. And then there is the small number shown in violet, but 7.5%, where there are uncommon dementias which are predominantly degenerative, like frontal lobe dementia, Jakob-Creutzfeldt disease, corticobasal degeneration, and some of the potentially reversible dementias. So that if one considers these as the degenerative, irrevocable dementias, then there is the other lot. The other lot are the symptomatic dementias, dementias that can be treated because the underlying pathology is an acquired pathology, which is potentially somewhat reversible. So this can be diagnosed when the dementia occurs in a specific geographical or historical setting. So if, for example, a patient who is seropositive for the HIV virus and then presents with a progressive cognitive impairment, the dementia then could be from either the virus effect itself, called the AIDS dementia complex, or it could be due to an acquired pathology like periventricular primary CNS lymphoma and so on. So there are various culprits to this. The commonest and the favorite for neurology discussions is primary CNS vasculitis. Then there is a form of vasculopathy called Hashimoto's encephalopathy, or the thyroid autoimmune thyroiditis associated disorder. There is lymphangioendotheliomatosis. So when there is a lymphoma that invades the vascular tree and produces multifocal neuraxis dysfunction within the brain, or it can be lymphoma with multiple blobs in the brain itself, in the deep white matter, or around the ventricles in its rarer presentation. Then there is progressive multifocal leukoencephalopathy. We know that this is caused by a virus that is inherently present called the JC virus, named after the patient. And this JC virus gets activated when an individual is immunosuppressed, as for example, sometimes in patients on therapies. Vitamin B12 deficiency, you heard Dr. Fali very elegantly talk to you about that. I alluded to Hashimoto's encephalopathy as it was known. Now it's known as steroid responsive reversible encephalopathy associated with autoimmune thyroiditis. And finally, there can be rare conditions like Whipple's disease of the brain. And in my lifetime, I've come across only one such patient. But it's important to know that these are potentially treatable, reversible, and they are a one-off event in a patient's life that can make the dementia present, but it can resolve. So what's the algorithm that we deploy when seeing patients? We need to understand the age of onset. We need to localize the lesion or the number of lesions that have been localized. We need to assess the tempo of progression. We need to ask the question, is it primary degenerative or is it the effect of a systemic dysfunction? Take inputs from appropriate investigations and then propose options for therapy. So having said that, this is the way we look at it. And when most of the neurologists are referred patients when there is a primary degenerative dementia, and the question is, doctor, what do we do about this? So what are the three common domains and types of primary degenerative dementia? The commonest is Alzheimer. We know that Alzheimer has a variable age of onset. It's characterized by memory impairment, preserved insight. The patient always knows that they're losing memory. If you ask the patient that, do you know that is what your relative is saying about your memory loss? Do you agree? They will always say yes. It is often associated with visuospatial dysfunction, and they may have started experiencing difficulties navigating their way within their own homes, or perhaps in their own locality, or in parts of the city where they live in. And personality changes come in later. In contradistinction to that, frontotemporal dementia has a different phenotypic expression. It has an earlier age of onset. It's often familial. There is a strong family history in a good 30 to 40%. It is dominated by a behavioral change and impaired executive functioning. And the impairment is essentially in judgment and frontal lobe social propriety. And there is no insight into the problem. If one asks the patient, do you have a problem? They would say, no, I'm fine. It's only my relatives who have brought me here. Language dysfunction can occur, but it often occurs late. And memory impairment can occur, but it often occurs late. And memory is not the dominant presenting feature. The dominant presenting feature is behavioral change and change in judgment. And the third common dementia degenerative that we see is diffuse Lewy body disease. Many of you in the audience may have seen your patients being diagnosed as DLBD by us, by me, Dr. Arun Shah, Dr. Singhal, Dr. Pocha, and others. So diffuse Lewy body disease characteristically has a very vivid presentation, and it presents because the family comes with a story of an elderly onset, usually beyond the age of 75, with vivid visual hallucinations where they see people or they see animals who are fairly benign, but they dominate the windowsill or the corners of the room, especially in the evening. This is associated with fluctuating cognition. There are good times and bad times in the day. There are lucid moments, but they are interspersed by periods of confusion. And there are good days and bad days, and sometimes there are good weeks and bad weeks. If you take a history, often a good number, at least 50% of these patients have a history of REM sleep behavior dysfunction. That means they have a habit of enacting their dreams in their sleep. And if you ask them, they say, yes, doctor, sometimes he or she makes movements as if they are dancing or they're playing cricket or playing football. And they can actually vocalize when they're dreaming. So they're actually enacting their dreams, and that's known as REM sleep behavior dysfunction. And on examination, these patients have subtle but distinct Parkinsonism. And again, as it is shown, the three different phenotypes of these degenerative dementias are fairly distinct, and a good clinical history and a good assessment should be able to differentiate what seems to be the core feature. So what is Alzheimer's disease? Alzheimer's is characterized by progressive loss of cognitive functions, memory, personality, behavior, language, visual spatial skills, praxis. This occurs due to neuronal degeneration and synaptic failure. It results in patients losing cognitive abilities and hence livelihood abilities that are vital for independence. And the pathological hallmarks are described in pathology. This is an accumulation in the brain, in the cells of the neurons of phosphorylated tau, and there is an extracellular deposition of an abnormal protein called beta-pleated amyloid. And this is called the senile or neuritic plaques of the original description about 100 years ago. And it is associated with amyloid angiopathy in the brain vessels. So this is what a slice of the brain would look like. What you see here are neurons filled with neurofibrillary tangles, which are abnormally clumped phosphorylated tau. And there are different isoforms of this phosphorylated tau, 17, 27, 39, etc. And what you see here are, again, extracellular deposits of what is called a neuritic plaque. These are deposits of abnormally beta-pleated amyloid oligomers 4042, and in association with these oligomers are neuronal debris. And why does this happen? Well, in a nutshell, there's some things we know and there's a lot that we don't know. We know that there is a genetic predisposition. There are genes which are responsible for the vulnerability of the brain to acquire these pathologies. There is an ApoE gene, there's a presenilin-1 gene, there's a presenilin-2 gene, there is a TREM2 gene, then there are rarer genes called SORL1 and TOM40, and there are genes which I'm sure will be described as time goes by. We know that there is a strong association with lifestyle risk factors. Metabolic syndrome, sedentariness, aberrant sleep hygiene, head trauma, and alcoholism can all predispose to this vulnerable brain becoming more susceptible by the acquisition of these lifestyle damages to the brain. What is not clear is that the physiology, what is it that initiates this process? We don't know. And what drives its progression? Well, we are starting to learn that there may be some factors which are being understood, but it's still very early days. And because of this understanding failure, many treatment trials till date have failed to halt or reverse the course of Alzheimer's disease. Somewhere in the 1990s, this association between obesity and Alzheimer's disease came about. So this was a Northern Californian study where there was a strong association between people who had an sagittal abdominal diameter. That means they were obese, and they were followed up for 20 years. And the obese individuals had a much higher risk of developing Alzheimer's disease as time went by. And that brought us to the association of these metabolic factors. And there was a thinking that in the cell, there is this GSK3 beta, which is a important factor that regulates phosphorylation of tau and microtubule structure, and allows microtubule structure to be stable or unstable. And this is vulnerable to diabetes, and many thought that it is diabetes and sedentariness that alters this GSK activity. And then about 7 years ago, we learned that there is a system in the brain that cleans the brain of amyloid and tau. We know that amyloid and tau deposits in the brain, and there's a system that cleans it when we sleep. And that system is called the glymphatics. This was discovered in 2003. So what is the glymphatics? It's a unidirectional flow of CSF. This is mediated only in sleep, and it abates as soon as we wake up because of adrenergic tone. It is best in the supine and lateral position. That optimizes it. And when you sleep prone, the glymphatic system functions, at least in mice and humans, at about 40%. Voluntary exercise and low dose alcohol does enhance glymphatic efficiency. Head injury, diabetes, strokes, and sleep apnea impairs glymphatic efficiency. And we now know that the glymphatic function is, amongst other things, to excrete beta amyloid and tau in normal asymptomatic individuals. That means every night that Joy Desai and Anil Mehta go to sleep, during their sleep, the glymphatic system is doing some house cleaning, and whatever little beta amyloid and tau has accumulated that day is excreted by the glymphatic system. And we have lots of emerging evidence that if sleep is impoverished in any manner, then it can alter the amount of amyloid and tau. You can measure that in the CSF, even in individuals who are cognitively normal. So this is a study that illustrates that you have cognitively normal people, but their poor sleep is associated with an alteration in the ratio of A beta 4240 and tau. And this ratio is similar to what you see in Alzheimer. But if sleep is replenished, it improves and becomes normal. So clearly, sleep has some modifying physiology on a daily basis on the clearance of amyloid and tau. And this is now being proposed as an advisory in Alzheimer's disease. You can see here that more research is needed. And one such research paper got published just last month on the 2nd of November. And Dr. Arun Shah very kindly sent me a blip when this came out. And this is a paper from California, again, from Joseph Weiner and Matthew Walker. Here they correlated poor sleep parameters by objective measurement of sleep indices on polysomnography, measuring the depth of sleep, and correlated it with the deposition of beta amyloid as measured on fluorobeta PET scans. And the authors now clearly mention that from their association of this data, that poor sleep is associated even in normal individuals with accumulation of beta amyloid. You can measure that on fluorobeta PET scans. They mention in their conclusion that the assessment of sleep, even with non-invasive devices like wristwatch actigraphy, will perhaps in future be a potential assessment for health paradigms and important for prevention of Alzheimer. I know that when we spoke the other day, I was asked by Dr. Shah that, will you tell us about prevention of dementia? And we know a few things, so maybe we can share some thoughts. And all of you might remember this movie, that's Amir Khan in the movie Ghajini that came about in 2008. And it was so popular because of him. And you can see here, he's written on his body, he has what was called in the movie short-term memory loss. That means short-term memory loss. And he's written here on his chest, Kalpana was killed inadvertently, so that when he looks at it in the mirror, he can read what he has forgotten. But this movie was actually based on a Christopher Nolan movie, which was made in 2000 called Memento. And Memento had a similar premise. And it brought the concept of short-term memory and its vulnerability to trauma into common understanding in lay public. So the question that we should be asking is, what is human memory? Well, the simplest answer to that could be that memory is the power or the process of reproducing or recalling what has been learned and retained through associative mechanisms. So we meet someone a few days later, and the brain says, hey, that's the man we met at the party 3 days ago. And this concept of memory being frail was also kind of become thrown into the spotlight in this very popular series. Some of you may have seen this show during the lockdown. It's called Blind Spot. It's been extremely popular. And what you see here is Sullivan Stapleton, who is the FBI agent, and this victim, Jamie Alexander, who has been injected with this protein called ZIP, zeta inhibitory peptide. And when she was injected with ZIP, all her memories were lost, and she could not remember who she was, and her childhood memories were deleted. So when I saw this show with my wife, she actually asked me, this was about 6 months ago, is that what is this zip? I mean, what rubbish is this? And I must say that at that time, even I thought that this zip was rubbish. But it appears that zip is not really rubbish. It's based on science, which has been unearthed by very lucid and beautiful studies done in mice. So Tom Sachter is the investigator in Boston who has worked on this. And what they have shown in mice is that when a memory is formed, many synapses get consolidated by a biological process called long-term potentiation. And for long-term potentiation to occur, a protein kinase called meristoylated protein kinase zeta is responsible for making and consolidating these synapses. And in mice, if you give an inhibitor to meristoylated protein kinase zeta, which is called ZIP, zeta inhibiting peptide, that mouse forgets all its memories. And this has been explored as the molecular basis, and that led to the premise in the show. Fortunately for us, there is no inhibitory peptide that you can inject and make people completely forgetful. So in a nutshell, the hippocampus is a receiving and processing hub that stores the immediate memories. Neurons, astrocytes have a complex mechanism of chatter, talking to themselves, and these form a synapse. And this cationic chatter, if it's long enough and loud enough, permanent patterns are developed, and that permanent pattern at a cellular level requires a protein kinase. And in sleep, there is a data transfer that occurs from hippocampus to the neocortex. It's like from the pen drive of the hippocampus to the hard drive in the big brain, parietal lobe, or the frontal lobes. And sleep rhythms, when we are sleeping, they are the connecting cable. And these processes are influenced by lifestyle. So it has a synaptic network which is complex. For consolidation to occur, long-term potentiation is important. And if long-term depression occurs, then these memories are lost. And that's the dynamism of the memory model. And these atypical protein kinases like meristoylated protein kinase zeta and iota and lambda, they are necessary for these synapses to occur. What basic scientists are exploring now is ways of improving the activity of these protein kinases so that they can be utilized in clinical practice. But we do know that sleep, exercise, stress, and meditation, these are all lifestyle influences which have a complex effect on the efficiency. In degenerative dementias, there's a pathological change in the brain due to bad proteins getting deposited. So there is cell loss, and this whole process is disrupted. Some emerging data implies that sleep hygiene could influence the speed of pathological decline due to the numerous beneficial effects of sleep on daily mechanisms. So, and we know now that obesity, diabetes, OSA, and head injury can alter the complex balance within these processes. So if somebody asks me, what are the ways, the electrical signatures of this memory transfer occurring in sleep, then we know that there are 3 electrical signatures that actually occur. There is an EEG activity called hippocampal ripples that occur on the transition from wake to sleep. Then there are slow wave oscillations that occur in non-REM sleep, in stage 2 and stage 3 of non-REM sleep. And in stage 2, there are sleep spindles, which we all monitor on the EEG of a sleeping patient. So it appears that these sleep spindles are the yoking of this slow wave activity to the ripples, and it seems that that is responsible for memory transfer. And if in poor sleep, these 3, so remember these 3 electrical signatures. So your sleep has 3 EEG signatures which are vital for memory to actually occur and to get consolidated. And that's the image that should help you remember that. And this is the original study which showed that if you learn, that learning can get consolidated when you sleep. And that's the hypnogram shown here with slow wave sleep. And the next day when the teacher asks the question, the student knows the answer because sleep has resulted in consolidation of this memory. And so this is the clear understanding of memory that we have today, that this is a complex process. We have got some ideas about how it functions, and we have some important information that tells us that trauma, diabetes, sedentariness can make it worse. Whereas if you want it to improve and stay good, we need to exercise, we need to sleep, we need to meditate. And you heard Dr. Arun Shah talking about Dr. Singh's passion. And it is passion that makes that memory strong. It is Dr. Singhal who's passionate about neurology, and he remembers 1980, he remembers polymyositis. And we know that pursuit with passion of what we do with passion is neuroprotective. And there is some data to show that. It's a little complex. But at this juncture, in the last few slides, let me quickly tell you why our brains are vulnerable as we grow older. As we grow older, this is the hypnogram in an infant, in a young adult, and later in an elderly person in the column on the right. So what happens in an elderly person is that slow wave sleep, these important slow wave sleep, which needs to transfer memories, that becomes much smaller in quantity, and it is replaced by a higher proportion, 70 to 80% of stage 2, which is slightly shallower sleep. And why does this occur? It occurs because of an alteration in older people of the sleep architecture. So there are a greater number of awakenings in an older person. Sleep is a little more fragmented, and the time spent in slow wave sleep is only in the early phases and not in the later phases of sleep. And this diagram shows you from conception to death, if one maps the type of hypnogram change that one sees, you can see that REM sleep and non-REM sleep and the time spent awakening, shown in orange, undergoes a proportionality change as you grow older from the age of 20 to the time of designated death. So we have a new science which clearly shows that in an older brain, because of atrophy of the frontal cortices, there is an uncoupling of this slow wave spindle synchrony. I told you about those 3 EEG signatures. They are synchronized. So this synchrony gets uncoupled when we grow older. Why does it get uncoupled? Because of atrophy of the medial prefrontal cortex. And that's been shown by this study by Matthew Walker, that in older people, the medial prefrontal cortex, as you grow older, shrinks, and that's what results in this uncoupling. So can we do something about it? Yes, we can. If we have head injury, if you're growing older, if you're binging on alcohol, and if you're depressed, it's shown on the left, then the medial prefrontal cortex shrinks. But if we exercise, if we are mindful, that means we meditate, if we do yoga, and if we follow passionate activities with a great deal of enthusiasm, then the prefrontal cortex been shown to not lose its architecture and not atrophy. So that's the balance. What can make it worse and what can improve it? So these are the lifestyle influences that can modulate it. We know that sleep hygiene can impact memory functioning. Alcohol consumption in excess can definitely disrupt slow wave synchrony and fragment sleep, and chronic consumption leads to prefrontal atrophy. Exercise improves flow to the hippocampus, improves neurogenesis, and improves cognition. And this is all mediated by brain-derived neurotrophic factor, which has been demonstrated in numerous studies to increase when we do exercise every day. Stress and anxiety worsen memory due to a suppression of this by cortisol. And there are numerous studies which show that people with chronic stress, and all of you may have seen stressed people come to you and tell you that their memory is poor, because cortisol again impairs prefrontal cortex activity with sleep transfer at night in sleep. So the take-home messages are that science is unraveling complex mechanisms that drive human memory establishment and maintenance. And this is moderated by many lifestyle factors, which can't be taken lightly. Diet, exercise, sleep, meditation, enthusiasm, passion, hobbies, and innovative activities. My conviction, every 5 years we have to innovate, do something new. If we did epilepsy in the beginning, then we got to shift to dementia. We did dementia, then we got to shift to something else which is exciting. And now the excitement is with sleep. Maybe 5 years down the line, we'll find something more. Degenerative dementias can produce impairment in memory. It has a distinct biological basis. There are treatments that can somewhat restore and rehabilitate function, but we are still at the cusp of the early part of this journey. And many of our patients can only be rehabilitated, but the disease cannot be reversed. But yes, we have got some insight into prevention, and maybe we should work on that. And it appears clearly that lifestyle is a major determinant of robustness of memory. And that should answer the question one of the senior GPs in the audience asked me the other day: how do we prevent dementia? Well, we don't know yet, but we have got some ideas. And for now, in 2020, these ideas will have to suffice. And that's my last slide. Thank you. I've tried to give you a kind of bird's eye view of how we see the science behind memory, dementia, the clinical. And I've tried to put it together in a little bundle, and I hope it's been of some use to you. Thank you. I'll stop here.
Thank you, Joy. That was a brilliant presentation. Your one slide had a title, memory in a nutshell. I think it should have been what happens to memory when your nut gets uncoupled in the shell. Thank you.
Thank you so much.
So I will now ask everybody to unmute.
And I'll stop sharing. So, yeah.
Please unmute. We shall start with the question and answer session. If anybody on the panel has questions to ask, we can start with that, or we'll start taking up the questions that we have received online on the YouTube.
Can I ask my question?
Yeah, please.
Sir, is there any blood test available as there was some news in the paper about the Alzheimer's disease?
Yes. Yes. So, yes, both Dr. Fali and I can give you a little snapshot. There is very early data now to suggest that one could measure a form of phosphorylated tau in the blood. It's called phosphorylated tau P27. And there is a recent study that seems to correlate with the amount of tau that's deposited in the brain. There is some understanding. This is for Alzheimer. This is predominantly for Alzheimer, not for other ailments. And there is also some growing perception that of the two deposits, amyloid and tau, it seems that tau is more detrimental to the brain than amyloid. And perhaps this will be substantiated by future studies. And clearly, there is a test for phosphorylated tau in the blood. It's still research. It's not mainstream. You can't do it in the lab today. But 5 years from now, who knows?
Thank you.
Fali, you'll have to unmute.
Fali, you're muted.
I was just that would definitely be a research thing. But I think for all dementia patients, you must do a B12 and thyroid test.
Oh yes, absolutely.
Fali, one of the questions was.
So Fali, I'll say that for all dementia patients, I'm no Dr. Arun Shah, will smile here. We must do B12, thyroid, and maybe a sleep study.
Yeah, sure.
One of the things, Fali, that I think with your presentation, I saw you had one presentation of thiamine excess. We're seeing a lot of people gulping vitamins left, right, center.
It's B6.
Sorry, B6.
Pyridoxine. Yeah.
Pyridoxine. It's pyridoxine.
We are seeing a lot of people taking far more vitamin supplements these days, especially now in COVID times. People are gulping down vitamins in huge quantities. A small word about whether
they should be exercising in huge quantity, but they're not doing that, and they're watching more Netflix.
Yeah. So, what about vitamin neurotoxicities and hypertoxicity?
Yes, so definitely B6 will cause neuropathy. Vitamin D, of course, can cause intrathecal hypertension. So these are the two vitamins, and vitamin A can also cause toxicity. All the fat-soluble vitamins more commonly. The water-soluble vitamin B6 is the one that causes an excess, causes neuropathy, and then ataxic neuropathy.
Because now they're talking of a lot of vitamin D3 receptors and retinoic acid receptors all over the body. So you don't really know what's happening with all of this.
Yeah, so I think avoid an excess of any vitamin.
I think that the take home that one can understand is that the human body is physiologically a complex network of numerous independent but very vital functioning processes. So anything in isolation that gets disrupted can influence the others. We now know about vitamin D and immunity, and if you speak to Dr. Om Srivastava, he always talks about pushing up vitamin D levels to 70 and 80 levels in a patient who's got chronic tuberculosis. So the infectious disease guys have jumped the bandwagon about vitamin D and immunity. And I'm sure that with the greater amount of science, we'll probably be able to understand this more as time goes by. But moderation and optimal health. So that is going to be the key. So the GPs are going to be important. We need to keep vitamin D in place, take vitamin C, maybe a little bit of zinc, B12, exercise, sleep, meditate, and like Dr. Singhal, passionately follow something.
That's wine.
Yes, a little bit of wine, Fali. I agree. A little bit of wine. I did say moderate alcohol protects the lymphatic system. I did say that.
We always see excess B12, 2000 plus and all.
Yeah.
So does it matter?
I don't think so.
It's a water soluble. So it's a water soluble. So
Dr. Arun Shah, we would like to know what Sir thinks. Dr. Arun Shah, do you think it matters?
I think it's not there.
No, no,
Anyone there?
yeah, Vijay.
Yeah.
Yeah,
Yes,
hi,
sir.
sir.
So I don't think B12 has any
Yeah.
toxic effect. We see, I think what is important is the concept that don't keep on measuring B12. You know, why people keep on doing serial B12? I just don't understand that.
Yeah, I agree, sir.
So I discourage them when they tell me 2000. I said, don't do it. It test doesn't help you. It's like in my senior, we keep on doing acetylcholine receptor antibody titer. It doesn't help us. So, you
And
know,
actually, and as a supplement, I think B12 even thrice a week is good enough. You don't need B12 every day. Even 3 times in a week, supplement is more than enough.
higher level doesn't matter. But of course, as Dr. Falipocha pointed out, pyridoxine is the great culprit. And I think one should be aware when you give a lot of grams of pyridoxine in a year, you're bound to develop ataxic neuropathy.
There are many questions on the chat.
There are quite a few questions coming in. So Dr. Jackie Waswani wants to know use of nuts in improving memory.
Yeah. In improving memory, I'm not sure, but
so
the whole goal of consumption of nuts, from what I understand from the nutrition point of view, is that micronutrients like magnesium and zinc, the highest content is in dry fruits and nuts. So if you have almonds and walnuts as a part of your daily diet, you don't need a dietary supplement of zinc and magnesium. So that's the dietary source. And we know that zinc and magnesium are important co-catalysts facilitating neuronal function at different levels. So about memory,
I think that
don't have a direct
there is
comment.
a Dr. Meena Samtani who wants to know, should memorization be done in the night before sleep or after sleep early in the morning? So should one be a lark or an owl?
No, so it's not a question of being lark or an owl. The question is what you put in your head before you go to bed matters, because whether you like it or not, if you're sleeping well, it will get consolidated as a memory. So they say that don't sleep on a fight, because if you fought and went to sleep, it's likely to be detrimental. At the same time, if you read something nice and motivating, if I don't know how many of you read Og Mandino. Og Mandino is a motivational speaker, and he has the 10 scrolls for success, the greatest salesman in the world. There are 2 books, you can buy them at a crossword. And his foreword says that each scroll has to be read at least once before going to bed every night. And if you read that scroll, then that becomes a part of your personality. So there is something there. So I'm not saying being a night owl. I would think it's good to sleep on time. 10:30 is a great time to be in bed. But what you put in your head matters, because that's going to remain as a memory.
There's Dr. Vishnu Namdas who has a question for Dr. Arun Shah. Can you please explain mechanism of hypoglycemia-induced tremors?
I think it's a sympathetic disturbance. The reflex mechanism procs at reflex oscillations, probably related to increased sympathetic activity.
Okay. Somebody also wants to know whether pregabalin can cause slurring of speech.
Yes, it can.
High doses.
Yes.
I think that's why the doses is important. You know, you start with a low dose and pick it up, it doesn't happen. But if you give high dose, it can happen. We have seen patients with acute onset of dysarthria because previous night he had taken pregabalin. It's not unusual.
And we are seeing higher and higher dosages of pregabalin being used in diabetics especially.
Yeah, I think you have to worry about creatinine levels when you use pregabalin, because the clearance is from kidney, and you'll have to stay low if you have impaired.
So I guess one should do 24-hour urine protein and make sure that there is no early nephropathy.
Sir, is there a rationale of combination pregabalin with nortriptyline?
Many brands are available.
I think the pregabalin and or gabapentin and amitriptyline combination, it has a different site of action, different mechanism of action. So it's a good drug for neuropathic pain, but I do not believe in prescribing a combination. So basically, I am totally against that, because you can't monitor doses, you can't control doses, and if you try to increase one dose, you are increasing 2 doses, and 10 milligram of nortriptyline has hardly any effect, in my opinion. Amitriptyline 10 milligram works, but nortriptyline 10 milligram doesn't work at all. So this combination is futile, and I think it has become a fashion these days. I always remove it and I prescribe separately, and I get results. Well, if you keep on prescribing combination at the subtherapeutic dose, you would not get results. So I think as far as possible, we should discourage people from using combination drugs, which of course it is for patients is good, but I don't think that's a way to treat medicine in my opinion. And obviously reason is 10 milligram of amitriptyline don't do anything. So they keep on moving around and then I remove that. I put 25 milligram, stabilize the dose and you get results. So I think combinations should not, fixed combinations are useless. What do you feel, Joy? I think that is why.
I don't use combination.
I absolutely agree. I think because our elderly are vulnerable and frail, it makes far more sense to do one drug at a time. In fact, if I do know that for neuropathic pain, we often use duloxetine and pregabalin, but I don't start both simultaneously. I would start a low dose of pregabalin, see how the patient does. If on a tolerated dose of pregabalin, the burning foot and painful sensations do not abate, then one can add duloxetine. Even the doses of duloxetine, in experience, many patients you can't even tolerate even 20 milligrams, and they just come back next day saying, "Well, doctor, what drug did you give me? I'm completely groggy in the morning." So every individual patient can be very sensitive. So using combinations is not a great idea at all.
Any more questions? Anil, you are muted.
There are many on the chat. There's one is Pacitan, the role for anti-tremors. Is there a role of Pacitan in treating tremors?
I mentioned anticholinergics are used in Parkinson's tremor. It has effect, and also sometimes in dystonic tremors.
And for Joy, this will be interesting.
Those anticholinergics, you have to worry about its side effect. Joy already mentioned, the question of delirium, question of worsening dementia is so high that as far as possible, when my strategy of Parkinson's treatment is when you are hello. Sorry.
Yeah.
You may use it to start with, but as the Parkinson advances or the person is becoming more old, I remove all anticholinergics from my therapeutic regime, and that probably is important message which I want to convey, that do not anticholinergics in advanced Parkinson's. It is
Fully agree. So I think as general practitioners, you need to understand when we talked about dementia, both in Alzheimer and in Lewy body disease, there is a hypocholinergic state. That means the amount of acetylcholine in the brain in Lewy body disease and in Parkinson dementia complex and Alzheimer's disease, the acetylcholine levels are low. And that low acetylcholine often drives their confusional spells and apathetic behavior and issues of functioning. If you add an anticholinergic, which also centrally depletes acetylcholine, it becomes worse. So Sir's point is very important. It is to be borne in mind. In a younger person, no hesitation in giving it. But if you have even remote idea that this person is not cognitively normal, be very careful about acetylcholine.
I was going through some apps for neurological diseases, and there was one app which I found which is used for the accelerometer in your mobile phone can detect the tremors that a person has, and it can actually give you a diagnosis by the patient holding the phone in the hand. Have you had a chance to use any of those? Anybody? No.
So as a corollary to that, there is a Taiwanese researcher apparently who's developed a gyroscope stabilizing device, which is doing the rounds. I wanted to ask Dr. Arun Shah, I'm sure with his vast practice, patients must have sent him the video. A lot of our Parkinson patients and essential tremor patients are sending the video of this gyroscope device that you wear on the hand, and the very large amplitude tremor of a postural tremor that the patient has gets dampened by the gyroscopic device, and they are able to drink from the glass. So yes, the technical advances of understanding the oscillatory mechanisms and damping them using a device is probably going to come. And this may become part of the mainstream.
At the same time, internet and exposure to the screens, LED screens, is affecting sleep and I think having neurological effects.
Yes. So there is some clear but unequivocal emerging data to show that blue light exposure on a chronic basis late at night after 9 p.m. Can drive insomnia literature clearly mentions that it can worsen insomnia because it depletes the brain of melatonin. So it demelatonizes the human brain and suppresses melatonin from the suprachiasmatic nucleus. So the VA cells in the SCN stop making melatonin on blue light exposure. So I think what's commercially developed now are blue light screens. So you can put a blue light screen on your device if they think that is important for them to finish their work on their devices till the time they go to bed. But I'm sure in time more literature will come.
Can you give some general tips for a good sleep hygiene?
Yes, I think sleep is like other things in the body, a habit. So if we recognize its value, then we will treasure its habitual maintenance. When I was younger, I used to sleep late, and now I've become very, very cautious. So I do get to bed clearly between 10 and 10:30.
Joy, you still are young.
No, I mean, in a manner of speaking, biologically, we know which year we were born. So I think sleep is a habit. So, and that habit can be nurtured and it can be made efficient. So when you drink coffee is relevant in the day, when you exercise in the day, I recommend few simple things to patients that if you exercise, try not to exercise vigorously in the evening, exercise in the morning so that the alerting effect of exercise does not impede sleep. If you have coffee before 3 p.m. Try not to have coffee late at night because coffee definitely blocks adenosine. And we know that adenosine is needed to initiate the flip between wakefulness and sleeping in the brain for sleep to actually occur. And again, about alcohol, everybody asks about this alcohol question. Pali asked about wine. So yes, we have a lot of data to show that more than 2 pegs of alcohol on a given night just before bed can decrease the amount of slow wave sleep and can produce sleep fragmentation. So if people like their alcohol, they can have their alcohol, but I recommend having it before 6 in the evening. So the Europeans are wise. They seem to drink earlier in the evening. And that's wise because by 10 p.m., 10:30, you've metabolized your alcohol and it's less likely to disrupt your sleep cycle. And timely habits, if your room temperature is optimum, if the lights are low and it's not noisy, then it makes it more amenable to sleep. And in those who wake up very often, if you notice that as you grow older, you are waking up more than 2 or 3 times at night and then drifting back to sleep again, in many patients, I recommend taking a small dose of melatonin. It is harmless. And there is this new concept of behaviorally induced chronic sleep deprivation syndrome. That means people who are even sleeping 1 hour late every night on a long-term basis, their brains behave as if they are sleep deprived, and they have the same problems of sleep deprivation as in others.
On the topic of melatonin, I started using a few patients with COVID on melatonin with very good response as far as the sleep is concerned. Because a lot of these COVID patients are now complaining of sleep disorders.
Yes.
And I found that the melatonin really helps them. And they actually, some of them who had this brain fog complaint also started doing better.
So you will know that some time ago, we did a meeting at the SRHN Reliance, maybe in February this year, last year? No, this year, February, we did a meeting where Dr. Mehul Shah, intensivist, spoke about delirium. And we shared with you some of the data that exists in the ICU. So even in the ICU, now melatonin is used to prevent delirium by optimizing their sleep cycle in the ICU, amongst other things. Of course, there are numerous facets to delirium, but one of the facets that needs optimization is their sleep-wake cycle. And there are ongoing trials, and there's a very large ongoing trial in Australia and New Zealand on melatonin for delirium prevention. So understanding melatonin, how it works, and its optimal utilization, that's going to happen. In the US, melatonin is prescribed as a health supplement. You don't need a prescription. You can just go to any shop and buy melatonin.
Fali, one of the last questions for you is, what vitamins would you like to take on a regular basis, especially post-middle age?
I think you should take a monthly vitamin D for sure, in a large 60,000 once a month. If you're vegetarian, you need to take some B12 and a combination of B vitamins. Vitamin C is useful as well, and a low dose of 500 per day as a supplement.
Great.
I think that about sums up everything. There are lots of questions still, but I think Most of them have been broached upon during the discussions. I don't need to take all of them. I think we will end the session today here.
Right.
Thank you. Thank
you.
all the speakers,
Thanks very
Dr. Arun Shah, Dr. Joy Desai, Dr. Fali Pocha, and of course, Dr. Singhal, for taking the time out and talking to us. Thank you very much.
Thank you.
Thank you.
Thank you. Thank you. Thank you.
Thanks. Bye.
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 Bye.